So we will be recording today's webinar, which is Interoception and the Heart-Brain Connection in POTS with Dr. Sahib Khalsa. So we are the Los Angeles Dysautonomia Network. We are a 501c3 nonprofit organization serving people impacted by dysautonomia in Los Angeles and throughout California through community, education, and financial support. We provide support group meetings for dysautonomia patients and caregivers so they can come together to exchange understanding and resources with people going through similar challenges. Community is at the forefront of what we do, and to help ensure that no one feels alone on this journey, we foster connection through in-person gatherings, our Cyclet book club, mindful movement classes, and our LADN links peer networking program. The matches are going out this week for anyone who's just joined the program. We all know how key knowledge is, especially when it comes to complex conditions like dysautonomia. So we offer webinars like this one where experts in the field share their knowledge. LADN also offers healthcare access grants, financial assistance to help low-income patients access dysautonomia healthcare. Last year, we offered grants to 10 patients. Of those awarded, the average income was about $16,000 a year. And the average that they had spent on dysautonomia healthcare in the year prior was $10,000. So that is an equation that does not work well, especially in an expensive state like California. We know that a significant portion of our members are unable to work due to this illness, and we believe that no one should have to forego healthcare because of financial barriers. So we offer this program every fall if any of you are interested in applying. Through these programs, we now serve about 500 dysautonomia patients and caregivers. We are reliant on community support, so if you're able, I hope you will consider making a donation today. Lastly, I want to invite all of you to our June 1st Unity and Community fundraiser. It should be a really fun event. There will be yummy food, raffles, silent auctions, and great community. So tickets are free, and I hope you will join us. Now, on to the main event. I am so pleased to introduce Dr. Sahib Khalsa. Dr. Khalsa is a psychiatrist and a neuroscientist who specializes in interoception, the brain's ability to sense and interpret internal bodily signals, and its role in mental and physical health. He is an associate professor in residence, director of anxiety disorders research, and holds the West Innovation Chair at the Semel Institute for Neuroscience and Human Behavior at UCLA. He also directs the Healthy Hearts Behavioral Medicine Program, an interdisciplinary collaboration with the UCLA Cardiac Arrhythmia Center, focused on addressing the mental health needs of individuals with heart conditions. Clinically, Dr. Khalsa specializes in treating anxiety and stress disorders, particularly in individuals with cardiac arrhythmias. His research explores how the brain perceives bodily signals during stress, using techniques such as brain imaging, computational modeling, and pharmacological and non-pharmacological interventions. By identifying how these mechanisms contribute to conditions like POTS, his work aims to develop new neuroscience-based treatments that improve symptoms and enhance quality of life. We are so grateful for his dedication to this important work and to have him with us today. I will now turn things over to Dr. Khalsa, and who will do a presentation before we open things up for a dialogue. All right, thank you so much, Dr.
Wonderful.
Khalsa.
Thank you for that kind introduction, Sally, and for the invitation to be here. So just want to double check again that you can see my slides and that you can see the mouse, because sometimes I'll move the mouse around on the screen for emphasis. So, yes, this is the title for the talk. Just to give you a little bit of background, I did my training at UCLA in psychiatry. I moved away for about 9 years to a brain research institute in Oklahoma called the Laureate Institute for Brain Research. I just moved back in the summer of last year. Also, there's no financial disclosures related to this presentation, so the research that I conduct is funded by the National Institute of Health. I'm a member of several executive boards in an uncompensated capacity. The work that I'm going to show you, I apologize in advance for those of you who are sort of overwhelmed by figures and text, because it is going to be somewhat research intensive. But I do want to get through this to give you a basic background before we have an interactive Q&A. The folks that you see on this slide are just a fraction of, believe it or not, of the people who have made this work possible. I do again want to thank the LADN and Sally and Emily for your support and hosting me to be here. So let's get on with it, okay? So we're here to talk about this funny term called interoception. So we're going to start with an overview. My hope is that by the end of this, you will be an expert in it, not only from the standpoint of experiencing it, because we all have brains and we all have bodies, but also a little bit, you'll know a little bit about the science of interoception. This image, by the way, is the Wikipedia page views for interoception. You can see that there was kind of a big jump in 2017 because I had some summer undergraduates in the lab who helped to revamp the page. But you can see that even since then, there's been really a steady increase in interoception that reflects kind of growing public interest in this concept. Okay, so let's talk about it a little bit more. This is a complicated slide. The only thing that I want you to see is this timeline on the x-axis, which starts at 1905, when the term interoceptor was defined by a British physiologist named Charles Sherrington. And then this blue line, which you can see has just been going through the roof in the last 15 to 20 years. So this is sort of the number of articles in the English language published on interoception. You can see that there's growing interest among the scientific community in understanding this. In 2016, when I had moved to LIBOR, I had the good fortune to organize the first international meeting on interoception and mental health. So this was a paper that came out of that where we worked as a community to try to come up with what's called a consensus definition. And this is what we came up with. Interoception, it's a process by which the nervous system senses, interprets, and integrates signals originating from within the body, providing a moment-by-moment mapping of the body's internal landscape across conscious and unconscious levels. So a lot of things going on in there. I'll point out a few things. A process, meaning it's something that's dynamic. The nervous system, and not just your brain. We'll talk about that. Then there's this aspect of sensing, interpreting, and integrating information, right? Each one of these is kind of has its own unique components. We're talking about signals from within the body, moment-by-moment mapping, and then this other curious element of conscious and unconscious. So conscious would be sort of something that you are aware of, that you can notice and perhaps report on. And unconscious are things that your nervous system may be sensing and processing, but you may not have that declarative ability. And if you look at the literature on interoception, you'll also see something called interoceptive awareness, which is really studied predominantly in the context of humans. And it's the conscious sensation, interpretation, and integration of information about the state of inner body systems. So something that requires a human to be asked about to then report on, okay? So if you think about the iceberg concept, and if interoception is the iceberg, then interoceptive awareness can be thought of as sort of the surface or the tip of the iceberg, sort of this component that you see above the surface of the water. And you can actually, in a very reductionistic way, kind of begin to tease it apart into different components. We'll talk a little bit about that, but they can be things like attending, detecting, noticing the amount or the intensity. If you think about when you're in the doctor's office and they ask you about your pain, right? Rate your pain intensity. Is it a 0? Is it a 10? Sort of how accurate or sensitive you are in terms of reporting signals, where they are located in the body. That's another component. And then there's a few other things as well. So we're beginning to make advances in understanding interoception by defining its components, both interoception and interoceptive awareness. There's a massive challenge, however, and that is when you actually take that definition, there's kind of a lot of things, a lot of physiologic processes that generate these internal body signals that span the cardiovascular domain, respiratory, gastrointestinal, bladder, hunger, thirst, temperature, flushing, air hunger, muscle tension, etc., right? So there's, in some ways, you could say that interoception is a very broad umbrella, there's also this discrepancy between painful and non-painful signals. So if I were in the room with you, I would ask you by virtue of hand raise if anybody here has ever had a kidney stone. Okay, I see one hand raised. There's always at least one. So this is an electron micrograph. This is an X-ray on the left and an electron microscope image of the surface of a kidney stone. Here it is in this individual's ureter. It's moving from here down here. And you don't need to be a scientist to see that if that thing is moving in your ureter, it's going to be causing incredible pain. In fact, it's often described as the worst, most intense pain ever experienced. In terms of a 10 out of 10, oftentimes people will say it's an 11 out of 10 or it's a 12 out of 10. Anyways, when we talk about sort of the distinction between non-painful and painful with interoceptive sensations, that's an important consideration to this complexity. There's another piece of this, which is that there's a valence arousal component. So a few years ago, I had the good fortune, I was giving a talk in Utah. I landed successfully in a blizzard and went snowshoeing. So here I am, 3 feet of snow at 8,000 feet. This was a happy side, okay? However, many of the patients that I treat, when faced with the same concept of increasing their autonomic arousal, for example, doing something healthy, like going to the gym, causes really heightened levels of anxiety and fear. And so there's this sort of concept where the same physiologic signal can create two completely different affective valences, and we need to understand why that is better. Another complicating thing with interoception is that we think of it really more as a brain-body feedback loop. So you have organ systems that are communicating these internal body signals to the nervous systems, and then you have nervous systems that then communicate to the organ systems. And if that communication leads to a subsequent organ system change, then you can see how there's this sort of cyclical component. As I mentioned, there are many different internal organ systems. And then there's also different nervous systems. So the central nervous system is the brain and the spinal cord, but it receives an incredibly diverse and important array of information from the autonomic, the somatic, as well as the enteric nervous system component. And what I would argue is that, remember in the definition, we talked about the nervous system. So it's not just the brain. The brain kind of sits at the top of this hierarchy, but it's really fed in an integral way by these other nervous systems. And we haven't actually even touched, we're not going to talk about the microbiome, which is a world inside of a world in and of itself. So suffice to say, there's an incredible amount of complexity. We're trying to understand it in terms of, as a neuroscientist, the neural circuits, but it's a different kind of neural circuit than you may be used to hearing in other contexts where people talk about just networks of nerve cells in the brain. As I see it, a neural circuit for interoception starts with sensors in these peripheral organs, with these peripheral pathways communicating through networks to reach signals in the brain going all the way back here that define not just your sense of whether an object is living or not, but it's really this sense of self. And this awareness piece is a critical component of the neural circuitry of interoception. Lots of brain regions are also involved in interoception. So the scientific community has often focused on one area called the insular cortex, and I will show you some data from our studies related to that. But every month, we're learning more and more about these areas of the brain, and sometimes new areas that are sensing interoceptive signals and that are involved. So it's not as easy as saying there's only one brain region or even one network. There are probably multiple networks, but we are learning a lot, and we're seeing that there is some segregation in parts of the brain. So you can see here's the ventromedial prefrontal cortex, here's the posterior midline cortex. We're also benefiting tremendously from animal models that are able to study in greater detail parts of the brain than we can in human beings. Here is a paper from last year that just gives an example that kind of surprised everybody, showing that there are neurons called mitral cells in the olfactory bulb of rats, which are involved in smell, that actually show a very rapid pulsation in less than 20 milliseconds in relation to the heartbeat signal. Why are nerve cells related to smell so quickly responding to heartbeat signals? Right. Again, we're just at the beginning of learning what the neural circuits of interoception are. Another challenge is that the symptoms that are related to interoception, I talked about conscious and unconscious processing. There's all of these signals swirling around in our bodies. We don't typically notice them. However, if something changes, if the homeostatic state of our body, if our normal balance is disrupted, for example, you experience heart palpitations, you experience difficulty breathing, maybe a suffocating sensation or flushing in the face. If all of a sudden your conscious experience is dominated quite noticeably by these sensations, and it tells you that there's something to be attended to, alert, right? And one question that we have to figure out is this a true alert, a true alarm, or is this a false alarm? We have to sort of figure out what the relationship of this sensory signal is to what our health is. Now, these symptoms that I've listed here are actually could be symptoms, diagnostic symptoms of many different conditions. I think that's probably no surprise to the folks on this call, that could be either psychiatric or medical, or not at all. They could just be part of normal physiologic function. So it's quite a challenge. Same thing is true for these other symptoms listed on the left. I'm a psychiatrist. So this is a chapter that I wrote recently in the first textbook that was published on interoception last year. And when we are using diagnostic criteria, we rely considerably on symptoms. These are symptoms associated with very different psychiatric disorders. These are all interoception-related symptoms. Unfortunately, we don't have diagnostic tests. These are signs that are associated with the symptoms that are necessary for the diagnosis of different psychiatric conditions. But unfortunately, we don't actually have any tests that we could utilize to identify, based on this information, whether somebody has a mood disorder versus an anxiety disorder versus a trauma-related disorder, et cetera. We're still in the early phases, really, of trying to better understand the neurobiology of psychiatric disorders with precision. This is a point that I want to emphasize because it's really critical for understanding interoception. There's this concept of homeostasis, which you can think of as like a reactive regulation, sort of the body automatically responding and perhaps adjusting to a need, versus allostasis, which you can think of as a predictive regulation. I like this figure because it explains the concepts very nicely. Imagine that this line X here is your blood sugar. And you know that every afternoon at around 3 o'clock, your blood sugar drops. And when your blood sugar drops, you kind of get hangry, right? You remember that Snickers commercial? Anyways, if you've ever experienced that irritability associated with a blood sugar drop, it happens to me. You know that, okay, well, if I just eat something to raise my blood sugar, then I'll be back in that homeostasis. So that's kind of the reactive regulation component. But if we were using allostasis, or our predictive regulation, signified by number 2 here, we could imagine that we would actually anticipate, every time that blood pressure drop, or that glucose blood glucose is going to drop. If I just eat something beforehand, when the drop happens, you'll notice that here it hasn't gone as low, and so maybe I don't get that irritable feeling. Maybe I don't get dizzy or lightheaded. So that's predictive regulation. And then you can then optimize and maintain your function. Now, I mentioned blood pressure as well. You could apply this to a blood pressure. You could apply this to many other interoceptive functions. There's a concept in the literature on allostasis that conceptualizes illness, disorder, or disease states as happening when your body's allostatic load gets too high. In other words, these predictive regulation mechanisms, there are actually many of them that are unconscious, even though I gave a conscious example, that when the body's regulation can't keep up with the body's needs, you then have sort of allostatic overload and failure, and then you have traumatic stress and other forms of pathophysiologic dysfunction associated with symptoms. So how do we how can we kind of better understand that? That's a focus of my research, but I want to kind of put a fine point on this before we have some of the interactive Q&A. So does anybody here see this? This is an old art piece. Does anybody here see the face in this image? Kind of hard, right? How about now? This is from 1590, right? So you see the face. Now you kind of can't unsee it once you've seen it, right? You've sort of formed that association. Well, here's another example. These are from the visual domain, right? So does this look like anything to anybody? Didn't look like it to me either. How about now on the right-hand side? Can you see the yellow letters, the B letters, right? So, so what I want you to imagine is that sometimes what happens is that the brain is filling in the gaps in these ambiguous stimuli. So imagine instead of visual stimuli, we're talking about interoceptive stimuli. So one of the ways that we think about one route to having a mood and or anxiety disorder is that instead of having an intact ability to sort of prospectively predict or understand bodily states, you have what's called an exaggerated prediction signal. So you're kind of anticipating that something will be abnormal more so than it really is. And in this particular example, imagine that the red line here is that type of individual. And when you have sort of a certain noise background of your internal signals, if you are not able to filter that noise from that signal, you may find more often than not that you are perceiving an abnormal signal from your body that may cause symptoms. So separating the signal from the noise is kind of a key element of what we think about in terms of understanding how some of these interoceptive disorders affect people. So that was an overview of interoception. I hope I have added some clarity. I probably added some confusion because this is complex information, but on the whole, I hope that that you have a little bit more info. So I want to share a little bit of insights from some of the research that I've been doing. So as Sally mentioned, I focus a lot on heart-brain communication, and this should explain a little bit of that sort of brain-body feedback loop. So the first thing that I would like you to kind of reflect on is whether or not you can feel your heartbeat right now. So if I was in a room with you, I would ask for a show of hands. It's a little bit difficult to get via the Zoom. We don't have an audience polling. But just for a moment, sort of pay attention. You could raise your hand on the chat if you'd like, and then we can see what you think. So normally when I ask a room full of people this, it's about half or more of the audience that indicates that they feel it. Well, it turns out only about 1 in 3 people. This is from unaffected individuals unaffected by sort of dysautonomia or psychiatric or anxiety disorders. But your average person, only 1 out of 3 can accurately feel their heartbeat sensation at rest. That's true whether you are an experienced meditator. That was one of the early studies that we did in my lab. It's even true if you have a heart transplant, if you have literally somebody else's heart beating in your body. On the other hand, we all know what it feels like for a heart to be beating, right? And there are a variety of conditions under which that experience is sort of prominent. Most commonly, heightened arousal situations. So it could be exercise, it could be anxiety, it could be stress, it could be sexual activity, it could be exhilaration, riding a roller coaster, right? And so the question is, how could we really best study people's sensation of their heartbeat if some of the standard methods, such as the ones shown on this, which involve things like simply paying attention to your heartbeat at rest, indicating whether or not you feel it in relation to a tone that's played in relation to your heartbeat. So how can we kind of get a better handle on this sensory signal when there's such a floor effect? So in my lab, what we have decided to do is to really emphasize and leverage our understanding of the neurobiology of the hypothalamic pituitary adrenal axis, or the HPA axis. So this is what this is the way that your brain helps to trigger the release of stress-related hormones in your body. They're being released all the time, even now, to different degrees. Much of the research on stress has focused on cortisol because it crosses into the brain and affects gene expression. But epinephrine and norepinephrine, so epinephrine, the other term for it is adrenaline, is a much shorter acting hormone that predominantly has its actions in the body. It's also, that's why you can think of it as a fight or flight neurotransmitter. And so what I've done in my lab is to take advantage of the fact that there is a medication called isoproterenol. Here's the chemical structure in relation to epinephrine. You can see that the only difference is this piece right here. To utilize that to systematically and safely modulate arousal in the body. So isoproterenol was originally developed in the mid-50s. It was actually the original asthma medication. But asthma patients, because it sort of increases the heart rate, it also opens the airways. Original asthma patients said, you know, I can breathe better during an asthma attack, but boy, my heart's really pounding in my chest. Could you do something about that? So they tweaked the structure a little bit to create something called albuterol, which you've probably heard of. It's sort of the rescue inhaler, which only works on the beta-2 receptor instead of working on the beta-1 and the beta-2 receptors. So it's a safe medication, and it does a very unique thing, which it very rapidly and transiently increases heart rate. This is an example from participants in our lab receiving either saline, sort of inactive control, a small dose, 0.5 micrograms, or a 2 microgram dose. And what you can, this is a sped up time course over 4 minutes. You can see that the heart rate increases a little bit or quite a bit, depending on the dose of the medication. We have established the safety of this and utilize this to now study perception, that sort of conscious piece of interoception that is essential. So this purple line here is a dial that participants are turning in real time to rate the intensity of the sensation on a scale from 0 on the right here all the way up to 10. And you can see that as the heart rate increased, so did the participants' perception of their heart. And this is under blinded conditions, so they didn't know when they were going to get the dose. And we can look at sort of the different time courses separated into a peak period and compare that in relation to the baseline. This is just an example of using many different doses. And this is now the dial course, time course. And you can see that a 2 microgram dose gets a very different response than a 0.5. When we look at these kind of detection curves, we can see that 100% of people at this particular dose feel it, whereas it's somewhere in the middle for 0.5, and you get your typical placebo response rate with the saline. This is what it looks like in a brain scanner. So if we're really going to better understand heart-brain communication, we need to be able to modulate heartbeat signals while we're measuring brain activity. So it took about 3 years for us to accomplish this, and for the last 9 years, we've been utilizing this particular approach. So we have a participant in the scanner. The isoproterenol is administered intravenously. We have a nurse who is monitoring them and also administering the infusion. And then we're sitting here on the other side monitoring their cardiac rhythm. And what we've shown is that this was the first study that we did. This was actually work conducted while I was at UCLA. So we first showed that indeed 100% of the people were feeling that 2 microgram dose. And at that dose, we showed that across the whole brain, there was this sort of selective increase that was dose-related in activity in the insular cortex, which is one of those key areas for interoception. We've subsequently studied this in psychiatric populations, and the only detail I'll emphasize is that using those same doses, saline 0.5 and 2, we found kind of a unique finding that individuals with generalized anxiety disorder showed heightened heart rate responses to that subthreshold dose that were associated with heightened perceptual sensitivity. So imagine at some point in the future, the ability to have a test, an objective test to measure somebody's sensitivity to their interoceptive signals. This is sort of maybe one future time point related to that. We showed we were able to selectively, again, engage the insular cortex, but to our surprise, we didn't see any difference in insula activation. Instead, we saw a difference during the 0.5 microgram dose in a different region of the brain called the ventromedial prefrontal cortex. This area of the brain has been associated with regulation of sympathetic arousal. And in this case, it was a hypoactivation. So the GAD individuals kind of turned off their ventromedial prefrontal cortex to a greater extent. The idea being that perhaps they were trying to regulate and tone down the sympathetic arousal to a greater extent, but they were unable to do so, leading to increased arousal. So this is you can probably get a sense as to where I'm going with this, with some of the research that I want to conduct in relation to conditions associated with dysautonomia. I will switch to that, and then we'll kind of go to the Q&A period, because I know that some of you asked questions, and I would very much like to get your input. So the first thing I'm going to say is this. When I think about dysautonomia, I don't think only about the heart, even though that's kind of a lot of what I've emphasized in my research and in the data that I've shown you today. There are clearly, because of the autonomic nervous system and its integral innervation of all of these internal organ systems, there are a variety of organ systems that are involved. So it's hard to kind of study all of them simultaneously to really sort of get a rigorous understanding of what's happening in a particular organ system. So I just want to indicate that to you that these are some of the other areas that we think of as being involved. This is actually from a paper that's going to be coming out soon in relation to Parkinson's disease, which has a lot of dysautonomia associated with it. What I'm going to focus on for the remainder of my comments is postural orthostatic tachycardia syndrome, or POTS. I recently wrote a grant proposal proposing to try to understand the role of interoception in POTS, and I'm very curious to get your feedback on this. I won't spend a lot of time defining it. Suffice to say that there's a unique component where it's described as having this excessive positional increase in heart rate in the absence of orthostatic hypotension, and in association with heart palpitations, dyspnea, dizziness, and lightheadedness. Affects 500,000 to a million individuals in the US. And although it can affect any sex or age, most individuals tend to be female and between the ages of 15 and 40, with about a 5-year period of symptom experience. Although that's written in research settings, it can be much longer than that, and that's sort of certainly well understood. It is really unfortunate that there are no major underlying mechanisms for POTS that have been identified at this point. This is a timeline of the publications related to POTS. What you can see is in the years 2023, 2022, and 2021, there was a huge increase in the number of papers on this topic, but still only 105 per year. So when you think about the overall amount of research that's being conducted, it's really a small fraction. Another challenge is that the diagnostic criteria have expanded since it was originally conceptualized in '82. As a psychiatrist, it seems to me that the change and the broadening of the criteria for POTS kind of reflects how psychiatrists have been defining psychiatric disorders, and also how gastroenterologists have been defining what are called functional gastrointestinal disorders. In other words, using symptom criteria to define these conditions that substantially impact people's health and impair their function, but they're being defined in the absence of these diagnostic tests. So really trying to refine our understanding of the mechanisms. My hope is that it will allow us to identify some tests. So the proposal that I wrote recently was really focusing on this concept that abnormal processing and amplification of interoceptive signals in POTS happens within a subnetwork within the brain called the central autonomic network. Raise your hand if any of you have heard of that before. Okay, so the central autonomic network is considered to be a set of brain regions that regulate autonomic function. So remember, the autonomic nervous system is the set of nerves that innervate peripheral organs. But what tells the autonomic nervous system what to do, right? So these are some of the regions that have been thought of as playing a role in the periaqueductal gray, for example, is a region in the brainstem that coordinates a lot of fight or flight responses. But then what tells the PAG what to do? What tells the hypothalamus what to do, right? The idea is that there are these areas that are above the hypothalamus and the PAG that play a role, and they've been thought of as this central autonomic network. So our hypothesis is that abnormal signaling within what we're calling a cardiac interoceptive neural circuit produces the signs and symptoms of POTS. And in particular, if we think of POTS as a disorder of cardiac interoception, that could sort of give us a framework to get a better understanding of the signs, but also the symptoms as well as the signs. So this is a complicated graphic. But the simple breakdown is that we think of these interoceptive signals coming in through the brainstem, through the thalamus, and interacting with the central autonomic network, as well as the ventromedial prefrontal cortex, which kind of regulates the central autonomic network. And when you have an abnormal amplification, either of the amygdala-mediated tagging of that affective or emotional valence, you have a insula-mediated increase in interoceptive symptoms, or an anterior cingulate-mediated increase in arousal, you're going to get some of the classic symptoms of POTS: autonomic amplification, hypervigilance towards the internal body, and heightened anxiety. So in order to test that hypothesis, what we would need to do is actually experimentally modulate some of these interoceptive signals and then identify whether brain regions play a key role in POTS. Okay, so for the grant that I proposed, we have conceptualized both what I call endogenous as well as exogenous ways to do that. So the endogenous ways are sort of a little bit, you could think of them as low intensity or lower impact at a certain level, because you imagine doing something like a Valsalva maneuver where you hold your breath and bear down, or you squeeze a ball as hard as you can for 60 seconds, or you subtract a three-digit number by 7 or 13, kind of doing a reverse math problem. Another option is in the scanner, because we can't stand people up. We have developed an ability to do what's called a passive leg raise, where we lift the legs in the air without moving the head, using a pulley system, which can change and shift the amount of blood flowing to the heart. These are, I call them endogenous because these don't change any of the inherent homeostatic set points in the body. And there's also kind of a fair amount of control that the individual has. So they sort of stimulate the brain-body feedback loop, but they do it in a less rigorous way than what you would get with what are called the exogenous ones. Isoproterenol would be the primary one, where we would be able to kind of manipulate the cardiovascular state in the absence of controllability. So, for example, if somebody doesn't want to bear down, they can just stop holding their breath, right? If the symptoms are too high or if they become too fatigued. Whereas with something like isoproterenol, in small doses, we're not proposing to use the 2 microgram dose, but really the smaller dose. There's the ability to kind of have a subtle manipulation to test for that kind of sensitivity of the sort that we saw in anorexia nervosa. In generalized anxiety disorder. So I think there's another sort of element called for modulating the parasympathetic nervous system called flotation rest. But I want to actually stop here so that we have time to get to the Q&A. And if I have a chance to address that, I will. Why don't we go to the Q&A period?
So if you all have any questions, well, first of all, thank you for that really informative presentation. I definitely learned a ton, very jam-packed with lots of detailed info. So I really appreciate that. So if anyone has any questions, you are welcome to raise your hands. Dr. Khalsa, I was also wondering if you had questions for the audience or any things that you specifically wanted feedback.
Yeah, I guess the main question that I have is when you think about the sort of idea of studying endogenous and exogenous heart-brain communication, sort of using these methods, what sort of response do people have to that? Does that sound reasonable? Does it seem like too much of a challenge? What are the likes? What are the dislikes? And suggestions for maybe things that I haven't considered?
Would anyone like to provide feedback? You're welcome to unmute and speak up or respond via chat as well.
Oh, the other thing I'll mention is that the grant in question that I mentioned, I hope, was reviewed on Thursday and Friday of last week. So there's been some uncertainty in terms of scientific review, whether it's happening at the NIH. The last information I had is that it was happening. So I'll be able to take your input and compare that with some of the scientific reviewers.
Hi there. This is Liz. Hi, thank you for your talk. When it comes to, whether we do the say Valsalva or that medicine, even though my symptoms are relatively mild in terms of heart rate, I would not be comfortable doing that medicine because I know how anxiety inducing it can be, and not having that control, I'm not sure if I would be comfortable doing such a trial. Even if it was for like a valid diagnostic test, I may be on the fence, let alone for it's not a clinical trial, but an experiment like this. So that's just my 2 cents.
Thank you for sharing. How would you rank that in relation to tilt table testing?
I haven't had a tilt table test. I can imagine it's kind of similar in. I think people, or they can be done in different ways in terms of how far to push it and what to give. I had the old man's diagnosis, laying down, sitting up, standing up. So, a tilt table test is more a diagnostic, and maybe if you were to do it in an experiment, it would be more, I guess it would be kind of in between the two for me, where it's, well known for PATS patients, and you can still put the table down and So it's, yeah,
Okay.
yeah, I guess in the middle.
Can
So-
I ask,
Oh.
sorry, just how high of a heart rate is that usually giving people? I don't remember if it said or on the chart.
Yes. Yeah, so there was also a question in the chat, would the dosage be similar to a nebulizer inhaler? So in this particular administration, let me go back to showing you the actual. Okay, so here is the 0.5 microgram dose in blue. So you can see that the heart rate increase on average is typically maybe 10 to 15 beats a minute, and it only lasts about 20 to 30 seconds. Maybe 60 seconds. So it's a very transient change. Certainly not if you were to sort of think about the time scale of when somebody would do tilt table, much less in duration. The other thing is, I think in our study we proposed 3 trials of the 0.5 microgram dose only. So we've used much higher doses. The normal heart rate ranges between 60 and 100. You can see that the 2 microgram and the 4 get at or above on average, where we are not proposing to use those. It's really this lower dose, with the idea that if somebody who has POTS is more sensitive, with the lower dose, it should bring about symptoms of heart palpitations and other sensations associated with dysautonomia that would kind of give us a better sense as to the likelihood of a POTS diagnosis, but B, give us a sense of what brain regions are doing. So is the central autonomic network indeed showing that heightened amplification or showing a failure to downregulate the way we saw in the generalized anxiety disorder patients? Good question.
It might be useful to first test it without the associated brain imaging, because like you say, giving the low dose may give you the high response that we see in normal people. And if I had to be in a brain scanner getting those palpitations, I don't think I could just stay still.
Yeah.
It's good to know it's short. That helps, I guess. But yeah.
That's a great point. And actually, we do in this proposal, and also in our practice, we always give people an experience of what it feels like outside the scanner. The way I explain it to people is I say, while you may not have received this medication before, if you know what your adrenaline feels like, you know what it feels like. And so then giving a low dose outside the scanner before you get in means that you will already have known what the drug feels like before you get in the scanner.
Yeah.
Even though the scanner environment may be new to you, the drug experience is not, right?
Yeah, that's good.
Okay.
Yeah.
Okay, that's very helpful. Thank you.
I see we had another question in the chat asking if participants are required to stop other medications, because a lot of people are also on medicines that sort of dampen the sympathetic response. So if you're asking participants to go off.
Yeah, we have that's a great question. And we have a detailed set of of inclusion and exclusion criteria where we look for if somebody's taking a medication that would counter the response or not be in their best interests, we wouldn't continue with them in the study. So I won't kind of go through it exhaustively, but for sure we wouldn't be asking people to actually take away medications, because again, that would not be in their best interest.
Another interesting question about whether you're looking at whether the dose response is as transient in people with POTS as people without. Are you looking at that timing?
We certainly would be able to. So we have, based on our psychiatric sample studies, as well as our studies of unaffected individuals, we could definitely look at that. The nice thing about the dial is that because people are rating their conscious experience on a moment-by-moment basis, these time curves, you can see sort of there's actually over here, there's a continuation of symptoms in some cases. And actually, let me see if we had it in this. I don't know if it shows up in this one. Maybe it doesn't show up here, but we have had other studies where, for example, at some doses, patients have had heightened symptoms that persist in the later stage. Okay. Next question.
Mara, would you like to go ahead?
I was just wondering if you had any data or information from dental research, because when I go to the dentist, I ask to not get norepinephrine.
Yeah. Yeah.
Novocaine and all of that, because I feel like I'm having a panic attack.
Yeah. So we have not utilized that. There's a substantial literature in cardiology with the use of isoproterenol because it's actually used at very, very, very high doses. Like I'm talking like much higher than what we're using for mapping of arrhythmias. We're using this at a really a micro dose. It's really well characterized at this point. The problem with the dental administration is that oftentimes they're administering epinephrine with Novocaine, and so there's sort of a locking in of the drug at the site, and there's multiple drugs on board as well. So it's not really the best comparison.
No, I would imagine not. It's just my example of like some serious interoception going on when I'm in that situation. And dentists haven't been very, I mean, they'll let me not use the norepinephrine, but most of the time I get people telling me, well, you just need to relax. And I'm like, it's not that.
Yeah.
There's a lot of things going on. And I just want to say thank you for this research. This is explains so much of my life. I've kind of come to the same conclusion. I thought I had anxiety for a long time, and I probably did, but I've had, I think, a lifetime of, overreaction in my body and feeling it, and then associating that with that it was anxiety. And recently I realized I was like, oh no, it's just my insides are reacting and I'm feeling it, and I have labeled it many different things. So it's
anxiety, the way I define anxiety is that it's a threat response in the absence of a threat-inducing stimulus. Now that's a little bit scientific for some folks, but if you think about threat from an evolutionary standpoint, we know a lot about the survival mechanisms that organisms have evolved to escape being somebody's lunch.
Right.
That allow a lot of autonomic coordination to fight or flight or freeze. But when you don't have a known threat in front of you, but you still have those reflexes being triggered, it's natural to feel on alert and apprehensive. And so we actually know more about the neurobiology, I think, of anxiety than we know about things like depression. It's very, there's a clear evolutionary background for it. And it's not that it's in your head, which is another sort of pejorative comment. It's in a brain circuit that spans, it's in a neural circuit that spans your brain to your heart, right? One thing I want to point out here, just with some data, you talked about sort of heightened sensitivity, right? So imagine your heart rate, goes up a little bit. Here we're talking about an elevation of a 3 out of 10 in our GAD population versus a 1.5 out of 10. So we're with the 0.5 microgram dose. So we're talking about a slight increase, but if that difference in the increase is enough to get you thinking or to enter your conscious mind and it can disrupt your function, right? It can disrupt your train of thought. It can make you start searching for meaning in your environment. What might be causing this, right? And again, it's not in your head. It's in a neural circuit that connects your heart and your brain that is survival associated. So it's a natural phenomenon. The unfortunate thing is that we don't have good tests to identify that
Right.
particular mechanism, and that's the hypothesis that we have for POTS that we're trying to go after.
Great. Thank you.
Yeah.
And would you like to ask your question next?
Yes, if during this type of test, the medicine, the drug is introduced at several different times, I'm curious to know if, as someone who has prolonged reactions to medications, how would that interfere with the response you're looking for?
Yeah. So good question. So, so I think we have to first think about what type of response we're talking about, because as you can see here, so in this study, for example, everybody got the same dose level twice. So this is actually an average. And so they got 6 total infusions in the course of a scanning session. So one thing that we can do is we can define what's the pharmacologic response or physiologic response. So did the heart rate change the second time? Was it more prolonged, right? Then we can also look at the symptom level and we can say, were the symptoms prolonged in terms of the heartbeat sensation, right? And then, of course, there's an affective component. So one of the things that I imagine us doing in this study, if we're funded, is to track that closely to determine whether there are adjustments that we need to make in the study approach, right? There's always trade-offs and limitations in between what you can study and you know how much time and funds and all those kinds of things you have. But if we were to find, for example, that everybody who with POTS had sustained responses, then we would have to adjust our design to accommodate that for sure. And another thing, if a single dose was sufficient to sort of establish that sensitivity, then maybe it would only need to be a one-time trial, right? So lots to learn.
Thank you.
So I know we're at 1 o'clock. I don't know if you have a hard cutoff or if you can stay a couple more minutes, Dr. Khalsa.
Yeah, I could stay a few more minutes if there's questions of people who are live. I know there were also a couple questions that were submitted ahead of time, and I can provide a little bit of some responses to a few of those as well. So.
Great. Were there any questions that stood out that you wanted to make sure to respond to? Otherwise, I can summarize a couple of them. I can send you them again too. I have them all.
No. So I have a couple. So so there was a question about non-pharmacologic interventions that could be most helpful for lowering symptoms or alleviating symptoms. Okay. And then there was a second part of that of how do we educate more doctors and then get it covered by Medicaid. I'm going to answer that in reverse. To get something covered by Medicaid and or Medicare or insurance, an intervention has to be demonstrated to be efficacious in at least 2 randomized controlled trials. Takes a long time, but really the answer is research. How do you educate more doctors? You do research and you publish it. Ideally, if it is an impactful intervention, you can begin to make both physicians and then the associated physician organizations aware. Patient groups such as the LADN could play a really strong role in terms of advocacy and making sure that that the understanding and awareness of new treatments is front and center. So those are sort of all the components. It takes a long time to do that. In terms of non-pharmacologic interventions, there is one that I'm kind of that I am interested in. It's not something that I have proposed to study in the grant, but it is something that I want to kind of put on people's radar called flotation rest or reduced environmental stimulation therapy. It's also called float therapy or sensory deprivation tanks. Is anybody aware of that, or has anybody ever tried that?
I'm aware of it.
Okay. So there's a whole nother line of work that I have conducted. And this is sort of taking the opposite approach from the internal bodily stimulation. And that is, if you reduce external body stimulation, can you reestablish homeostasis and reduce anxiety? So this is an example of what a flotation tank looked like at the previous institution that I was at LIBOR. This is an open float pool. This is an example of an enclosed float pool. So this is an 8-foot diameter tank with 11 inches of water in it. You put about 2,000 pounds of Epsom salt. So bath salts, the kind that doesn't make your skin prune, so more salt than the Dead Sea. That's why the reason they call it float therapy is you can stand in it, but when you lay down on the water, your body surface area increases and you float effortlessly. You don't have to hold your breath. You don't have to tread water. You don't have to tense a muscle. The water is heated to the surface of your skin, and the air itself is also heated to the surface of your skin. And so the idea is you are attenuating all kinds of inputs. So if this is your brain, there's really, the room is also dark, so dark that not even a single photon of light hits the retina. You're not moving, and there's nobody talking to you because it's a soundproof room. So you're attenuating proprioceptive and auditory input. Nobody's touching you, and you're not touching anything. You're not moving. So you're really attenuate, and you're not speaking to anybody. So if you think about reducing all of the activity in the neural circuits associated with these functions, one of the things that can come through loud and clear is interoception. And so we've actually shown that. This is a single float study with my colleague, Justin Feinstein, where we showed that there was sort of an improvement in anxiety, reduced muscle tension, increased relaxation, reduced anxiety, but at the same time, an increase in the sensation of the heartbeat and the breath. So a little bit of a paradox, different from the isoproterenol stuff that I talked about. We've done feasibility studies of this in anxious and depressed samples, in eating disorder samples, in substance use disorder. This is a phase 3 efficacy study that we published a couple of years ago now. So this is one of those criteria that you would have for getting Medicare approval, right? You need 2 efficacy studies. So you could think of as, this was an efficacy study showing an acute reduction in anxiety that was quite large this was in patients with anorexia nervosa. But you can see on a session-by-session basis, a substantial reduction in anxiety. We also even saw a smaller but clinically meaningful improvement in body image that was sustained at 6 months. So we haven't tested this in POTS, but in terms of the concept of a non-pharmacologic treatment, I think that would be another area that I would be interested in going. That was one question. Sally, do you want to maybe ask the most salient one that you saw of the written ones? I know there was also another hand in the chat.
Sure. Well, I think there was just a lot of interest in interoception in general and how what role it played in things like nausea, like inappropriate sinus tachycardia, and then I think a couple of other questions too asked about the relationship between interoception and POTS and neurodivergency and autism. So I don't know if any of those topics spoke to you. I know Alex also had a question with their hand raised. So in terms of timing, not sure where you'd like to go.
Well, why don't I try to address some of that first, and then Alex, are you okay to hang out for a second for your question? Okay, cool. So there has not been a lot of study on POTS and interoception in general. I wouldn't say that the available evidence base is anywhere close to being enough to tell us what interoception looks like. To give you an example, the sample sizes that have been done in POTS studies have like 8 people or 11 people in them, which is really not enough. There was actually a study that did involve isoproterenol administration, showed that POTS patients had a greater tendency to endorse things like heart palpitations and dyspnea during the receipt of isoproterenol. but we just don't know. In terms of neurodivergence, there is a group in England that tested a therapeutic intervention trying to improve interoception in individuals with autism, sort of high-functioning individuals. What they did was they used a non-pharmacologic version of isoproterenol. So they had patients do what they called star jumps, which is just the British term for jumping jacks, right? And they had them do that. And then while their heart rate was still elevated, they had them do a heartbeat perception task. And then they gave them feedback. They said, okay, well, here were your answers. Here's how accurate you were. And then they had them do that a few times to try to kind of align their perception with reality. They showed that in that study, there was, at 3 months, there was a slight reduction in anxiety in the autism group receiving the intervention relative to the control. It was a very small effect, by the way, but that's probably the best example of what's out there. And if anybody's interested in the paper, you can email me and I'll be happy to send it to you. Okay, why don't we go to the question?
Great, Alex.
Hi, thank you so much for doing this. I have a maybe two-part thought, and one is before I got sick, I worked in addiction treatment as a counselor. I remember reading a study back then that said one of the biggest predictors of addiction in adults is children and adolescents who, it said they have an inappropriately high emotional response to physical, what's the word, like feelings they feel inside their body, which sounds like exactly what we're talking about, right? So that's something I remember feeling as a child. But I was really curious about something. Well, I was curious first about if you had done studies in people with addiction, which it sounds like you have.
Yeah.
My question though is, towards the beginning, you said something about air hunger. I've never really heard doctors talk about that, and it's something that we talk about in the POTS community, and I've always it's a big problem for me, and I'm curious. I've never really understood what causes it or why we experience it so strongly, and I was just curious if you had any insight
Sure.
to that.
Let me start with that. So how do you define air hunger, or how do you experience it?
Me?
Yeah.
I feel physically out of breath. Sometimes I'm literally bent over, huffing and puffing, like I just did a sprint, and it's like I need to catch my breath, but just from walking from one room to the other. But I've noticed I've been IV dependent for 12 years for nutrition and hydration due to GI dysmotility. When I'm hydrated, I don't experience it at all. When I'm like actually hydrating, or I've just finished hydration, but when I'm not hooked up yet for the day, I can barely walk without. Yeah.
So thank you for sharing that. There is sort of dyspnea is sort of an umbrella term that includes things like air hunger, right? So drive to breathe, or feeling of difficulty breathing, or an incomplete feeling of inhaling, or feelings of suffocation. Those are all kind of things that fall under the umbrella of dyspnea. And they may not all be the same. They're probably not, in fact, because your neural control over the lungs is quite fine-tuned. Humans have much more control over their lungs, the sort of voluntary control over breathing, than we do over the heartbeat, for example. There are some studies that are emerging that are looking at influences of higher brain centers on breathing. So you have a nucleus in your brain stem, the brainstem portion, called the pre-Botzinger complex, that is one of these areas that regulates respiration in an automatic way. But if I ask everybody to hold your breath, right, we can all do it, and we can control our breathing patterns. And so there's a whole other layer of brain circuitry that can then regulate the functioning of the pre-Botzinger complex. And so there are hypotheses about unconsciously mediated brain circuits that impact the brainstem breathing circuitry. A colleague of mine and I, also Dr. Feinstein, we wrote a review article on this in relation to a hypothesis about anxiety, sort of a feeling of heightened feeling of suffocation that some individuals with anxiety report, that puts together a line of research that suggests that the amygdala is a brain region that seems to be able to exert control, automatic control outside of conscious awareness on breathing patterns. And it can, in fact, trigger changes in breathing that might elicit the sensations that you describe as air hunger. Now, I can't say what that circuitry is doing in your case, nor do I have the confidence based on the available research to say what it's doing in a particular disorder. But given that sort of increased interest in interoception that I described, there are more people who are starting to study what's called respiratory interoception. So I'm hopeful that we'll begin to get better information about the different mechanisms, the different types of dyspnea, and how that relates to different conditions. The piece about addiction, I would just say that abnormal interoception has been hypothesized to play a role in the cycle of addiction, and in particular, feeling sort of aversive sensations of interoception being related to the cycle of withdrawal and use and craving. So it's front and center in models of addiction as well.
Thank you for those answers, Dr. Khalsa. I really appreciate everyone engaging in this conversation. Dr. Khalsa, this has been so informative. I was wondering if you might just speak briefly about, I know we've talked about your research. We are always on the lookout for doctors who are informed about POTS. So I was wondering if you might speak a little bit about, do you see patients and what your practice looks like, and if people are interested in seeking your medical expertise?
Sure. Yeah, I do see patients. I work, as you mentioned in the intro, I work closely with the UCLA Cardiac Arrhythmia Center. And really the focus has been on helping people to manage anxiety and stress related to this abnormal heart-brain communication cycle. So it's very helpful to work with the cardiologist, because I'm not the one who will be diagnosing POTS or the other cardiac arrhythmia in the patient populations that I work with. And it's helpful to work closely with the cardiologist to kind of get a sense from their perspective, what's cardiological and what's not, right? And then from there, it's really helpful to then work with patients to sort of help reduce their symptoms. I mean, at the end of the day, that's the goal. So yes, I do see patients. If you know somebody who's looking for a referral or wants to be evaluated, you can reach out to me. My email information is on the web. If you're needing to get a hold of me and you can't find it, reach out through Sally, and I'm happy to communicate with you as well. And we can take it from there.
Well, thank you for spending this extra time. I really appreciate it. And I'm very grateful for your focus on the POTS community and continuing this research.
Thank you again, Sally, and to the LADN, and thanks to all of you who have been here. I really hope that we get a favorable review on this grant cycle, and if we were funded, I look forward to the opportunity to share some of the insights of what we're learning.
Absolutely. Well, our fingers are crossed, and we look forward to that. Thank you very much, Dr. Khalsa, and thank you everyone for joining us today.
All right, take care.